All right, good afternoon, good morning, and good evening. Welcome and thank you for joining us today from around the world and especially from here in East Africa. My name is Carol Oyola, Regional Communications Manager here at Aga Khan University. And on behalf of AKU, I am delighted to welcome all of you to our Connecting AKU webinar series. Now, this series is especially curated to share AKU's transformative work, research, new initiatives, and it's finding new opportunities to make the world a better place during this pandemic and beyond. Now, today's webinar looks at how the pandemic disruption is an opportunity for us to look at how AKU is using technology and telehealth even more. It's also for us to find a way to think ahead, collaborate, and innovate to create areas of opportunity. Now, we have two distinguished speakers from AKU with us today, Dr. Shawn Bolouki, Vice President of Health Services at AKU and CEO of the Aga Khan University Hospital here in Nairobi, and Dr. Mansoor Saleh, the Founding Director of AKU's Cancer Center here in Nairobi. Now, to moderate the conversation, it is my pleasure to introduce my friend and former colleague, Eunice Kilonzo, who is the Manager of Content Generation at Safaricom. Now, just a few housekeeping rules. The session will run for 60 minutes, and Eunice will then moderate a discussion with the panelists for about 30 minutes. And then we will take questions from the audience. Now, please do not put your questions on the chat box. To ask a question, you can email connecting.webinars@aku.edu. That's connecting.webinars@aku.edu. Eunice, over to you.
Thank you, Carol. Thanks so much for the intro. Thank you for setting the stage for us. Hi, everyone. Good morning, good afternoon, good evening for those who are joining us. As Carol says, we would really be discussing about, the opportunities that technology is offering us during this time to advance healthcare in East Africa. And well, as you've been told, my name is Eunice Kilonzo, and I'll be your host for the session that we have today. Just a bit of a background. Technology has really been a game changer in most industries. And this pandemic has particularly showed us the vital role technology can do and can offer for not just the world, but also in East Africa as well, particularly targeting, healthcare in underserved and rural communities. Therefore, technology really is that bridge for us to bridge this gap. And I'm glad that today we're joined by Dr. Shawn Bolouki and Dr. Mansoor Saleh, who will share with us how the Aga Khan University is making strategic investments in technology to broaden reach and access to quality healthcare for all East Africans. And our discussion will really look at the importance of private enterprise and civil society institutions to come together and to provide equitable and inclusive healthcare in East Africa. As Carol said, you can share your questions to connecting.webinars@aku.edu. That's connecting.webinars@aku.edu. So I'll quickly jump to introduce our speakers, distinguished speakers. I'll start off with Dr. Shawn Bolouki, who's the Vice President of the Health Services at the Aga Khan University and the CEO of the Aga Khan University Hospital, Nairobi. Dr. Bolouki has over 20 years leadership experience in healthcare. He's achieved major financial and operational success in acute care hospitals and medical care centers, large and small. His experiences span different hospital types, including academic, not-for-profit, faith-based, investor-owned, including as well as government hospitals. Previously, he served as the Chief Operating Officer and Chief Executive Officer for various hospitals in California and in Germany as well. And so that's Dr. Bolouki. I'll quickly shift to Prof. Mansoor Saleh, who is a professor of medicine and pathology. He's the founding chair, Department of Hematology and Oncology, and founding director at the Aga Khan University Cancer Center in Nairobi. Professor Saleh traces his roots in East Africa, having had his early education at the Aga Khan school system, and then he went on for his medical education at the University of Heidelberg in Germany, and he conducted his doctoral research in Heidelberg at the Max Planck Institute of Medical Research. He's received comprehensive clinical comprehensive cancer care skills at the Birmingham, Alabama, where he was a tenured professor of medicine and pathology, and his area of research and clinical focus is targeted therapy of cancer, and he recently joined the Aga Khan University in Nairobi as the founding chair, Department of Hematology, Oncology, and currently the founding director at the Aga Khan University Cancer Center. So you can tell they're prolific speakers. They have a wealth of knowledge and skills that they're bringing on the table. Just a brief about me is that I'm a writer and a storyteller with a keen interest in health, science, and development. I'm currently a content manager, a content generation manager at Safaricom, at the African Population and Health Research Center, where I met Carol. And I'm also a trained journalist as well. I've done journalism for close to 5 years in East Africa. And then I've also worked with the UNEP on issues of writing, really writing science and development issues. So with that, all that background, I want us to jump right into it and start off with our discussion this afternoon, morning, midday, depending on where you are. So I'll start off with the first question to Dr. Bolouki. We are living under the cloud of the COVID-19 pandemic. It's caused massive disruption to the healthcare system in Kenya and in East Africa. It has revealed underlying fundamental issues in all sectors. What has been the impact of this in the health sector, Dr. Bolouki?
Thank you for the questions. We need to look at this one in the context of the developed world and versus the developing world. If we look at it in the context of the developed world, let's say in US, North America, one of the issues that we heard in the past 15 years in this part of the world, it was actually an evolution of telemedicine. But it never really started until we had COVID. And COVID basically forced people to start thinking differently about the different mode of delivery of the healthcare. During the COVID, there has been 1 billion visits in US that they utilized basically telemedicine. Unfortunately, in this part of the world, it brought different realities to the surface. The first issue here is we need to understand what are the needs in Africa. If you look at in East Africa, one of the issues in East Africa is a lack of human capacity. If we look at the World Health Organization, and we look at just the 3 East African countries, Tanzania, Uganda, and Kenya, these countries, based on the existing population, not taking the population growth into the consideration, they need more than 120,000 doctors and more than 300,000 nurses. Now, developing that capacity is not an easy task, okay? Therefore, a telemedicine can play a role to some degree, mitigate that lack of existing capacity. But the things that came to the surface when we look at it, for example, we realize that the infrastructure in Africa is not sufficient. We did not have sufficient critical beds. We didn't have sufficient human capacity. The training is an issue. Some of these issues can be mitigated by technology, but in order to be able to take advantage of the technology, we need to understand the technology and human capacity. They are complementary to each other. I give you an analogy. You know what? If I have a sport car that can drive very fast, but there are no freeways, what difference does it make? Because I cannot get the full use of the car. Now here, when the counties and everybody run and started building ICU, but they didn't have a trained intensivist and the critical care. We spend the money, we basically put the infrastructure, but unfortunately, that synergy between the human capacity and technology could not be achieved. And you cannot, for example, make somebody an intensivist in 2 weeks or 4 weeks case. These are some of the shortcomings that came up. But I think there is a hope, and that hope is that telemedicine can play a vital role to some degree, ease some of these challenges, but we need to also be aware that the infrastructure at this time, it is not available here. And many people, they understand because they think they can use Zoom or basically FaceTime. That is telemedicine. It is not a telemedicine. It is a form of consultation. I hope I answered your question.
Yes. And Dr. Bolouki, you bring up very important discussions that what is telemedicine vis-a-vis what is on the ground and what is on paper sometimes is very different. What happens in the developed countries and what is in developing countries is very different. And truly, as you put it, is that this pandemic in particular has triggered that there's a demand for digital health technologies for populations to be screened, for them to consult, for them to track the infection. And I want to bring in Professor Mansoor in this discussion, that this demand for these services is here. And we're seeing that more and more countries are trying to find how then we bridge the gap, how do we meet the people who need these services and the doctors who have these services. And so we're bringing this closer home in the face of the pandemic. How does this look like in East Africa, especially in underserved communities? How does telemedicine look like? And how has the Aga Khan University stepped in your various capacities to meet this demand or address some of these needs?
So thank you. And I think I will continue where Shawn left off, or just continue his thought. It is true that what COVID has done is three things. It brought an infectious virus that can infect many people just by breathing. It detached us from the patient we were supposed to serve. And those who are far in the remote places were totally disconnected from the main hub of clinical care. So very quickly, we had to devise ways to protect ourselves against the virus. Masks, respirators. Can we now ventilate 6 people or 3 people with 1 ventilator, knowing very well that we have very few of those? And that is where technology really came up. COVID did not invent technological advances. It just accelerated the pace with which technology was brought to the forefront. And small things that already existed all of a sudden became very useful. The wearable technologies, iPhone or whatever you use, the iWatch, all of a sudden it can take your pulse, your blood pressure, maybe even take your oxygen saturation. We realize that those are things that can bring the patient closer to the clinician. But that infrastructure, to be able to have that platform, has to be there. The resources that for every individual to have a wearable technology does not exist. But I think what it did for us in sub-Saharan Africa is, with teleconsultation, we could at least talk to the person, at least provide hope and that connection. But beyond teleconsultation, we have to have teleradiology, telepathology, teleradiology, pathology, and all other components of it that we have not developed as yet. So I think between Shawn and me, I think we know the needs, but private enterprise can do so much. The government has to come in and provide those roads so that Shawn's fast car can really drive on those roads. So I think that is where public-private partnerships are very important. We've done our part. I think incredibly, we've been able to ventilate 2 people with 1 ventilator. We've had young people use the 3D printers at home that they use for just hobby to make wearable masks. We'll be able to increase the telepathology and teleconsultation services. But I think we need to do more, but it requires the infrastructure that I believe becomes a federal government or public institutions' responsibility.
I like that you talk about the key role of public-private partnerships, because some of these things cannot be done by one party or the other. You need to have synergies for you to work together. And also, just as a follow-up to something that you talked about, how COVID, not just as a viral infection, it came in really to push and put away patients from their doctors. So that's a challenge. So, the human to human connection is no longer there as it was before. What other challenges do you see in as much as telehealth is really a game changer, it's revolutionary because of how it brings access to healthcare? What other challenges do you see with healthcare, with telehealth in East Africa?
And I'll let Shawn finish my thought. But my thought is clinical medicine is the trust between a patient and their clinician. That touch of the clinician's hand on the shoulder of the patient, the auscultation, provides that hope and trust to say you care about me. The machine, Zoom between two, does not create that hope. Patients were afraid to come to Aga University Hospital, Nairobi, because they thought it'd be a highly infectious environment. So we, Shawn and his team, had to provide that trustworthiness to say, we're a safe environment. You can still come and be touched by a clinician. And those who do not need that tender touch today, we can at least connect with you, look at your problems, call you back to say, come in now, or wait until you are a little bit sicker, or wait because your entity does not require acute care. I think Shawn should talk about the ability to create that hope and trust in the institution that allowed the patients to come in, because all of a sudden we were considered a very sanctuary place where there are more viruses than in downtown.
Thank you, Professor Mansoor. Regarding what are the obstacles for telehealth? Before we get to the obstacle, really you have to understand the delivery of the healthcare. When you look at the delivery of the healthcare, you can define it as what I call it, is sequential and parallel processes. And you can divide it in the four major components. The first component is basically a prevention. The second component is diagnostic. The third component is basically intervention. And the last component is the continuum of care. Now, if you look at these four basically segments of the healthcare, the discussion becomes, what are the obstacles for each basically segment of the healthcare, and what are the necessities? Because you need to look at this one as an ecosystem that each step is contingent upon the other step. Now, if you want to move smoothly from diagnostic to intervention, then you do need an infrastructure, and IT, basically information technology plays a very big role. But let's talk about some of the basically obstacles in a very macro. When you look at it, one of them, the number one is patients. Now, why do you think the patients are obstacles? When we look at it, we need to be basically aware of the generational gap. Do not expect somebody that is 70 years old to feel comfortable to get on the telemedicine when they value a face-to-face interaction with their physicians. Now, if you are talking about somebody who is 18 years old or 20 years old, which has been grown up with the PlayStation and the video game, most probably they feel much more comfortable. But as Professor Mansoor also mentioned, at the end of the day, when we look at the delivery of the healthcare, it is about human interaction. It's the comfort level that you get when you are sitting with your physicians and you are talking to them. Okay, one of the obstacles is the patient and generational gap. The second obstacle is payers, insurance companies. One of the reasons that basically healthcare in the US was not very successful in the first 10 years, because there was a different payer mechanism. Insurance didn't want to pay for it, Medicare didn't want to pay for it, Medi-Cal didn't want to pay for it, and when people, they had insurance, they want to use the telehealth, and the physicians, they were expecting people to pay for it, okay? Insurance in this part of the world is not mature. The other obstacle is the regulatory requirement. The regulatory requirement in this part of the world, even in the developed world, has not kept up with the evolution of technology. Recently, in November, when the government of Kenya basically passed the law regarding the protections of the patient's data, this created a huge obstacle for us because we were trying to develop our our telehealth, but we realized because of the regulatory requirement, we could not basically store any data regarding to any Kenyan patient out of Kenya. And then the cloud computing became an obstacle, okay? The other obstacle, as I mentioned before, is the infrastructure. If you want to have a very basically effective telehealth, you need a 5G basically infrastructure in order to expedite the transmission of the data, okay? That doesn't exist right now. The other obstacle is, for example, a very simple thing. If you want to look at the teledermatology, you need to have a high resolution camera, high resolution monitor in order for the physicians to be able to see things in a very clear way before they can render an opinion. Setting up one station for teleradiology, for telemedicine, with basically digital stethoscopes, high resolution camera, high resolution basically monitor, a minimum investment is $25,000. But even when you have all those things, if you don't have a fast internet, you're not going to get the full benefit. Those are some of the obstacles. But, acquiring technology is very simple. Implementing it is a different issue. And then there is a very interesting dynamic here. The reason I say payment is important. If I am a physician and I see you face to face, just for the sake of discussion, I will get 1,000 shillings. But if I have to do it through telehealth and you want to pay me 500 shillings, the question here is, as a physician, there is an opportunity cost for me. Why do I want to do that? If you pay me the same, then that obstacle goes away. Those are some of the challenges that basically exist, and you need to educate insurance company, regulatory bodies, government, infrastructure, patients, and we need to look at telehealth as an evolutionary process. It is not something that today you implemented is perfect, but gradually we're going to get to a point that it might be a mature technology that it can benefit everybody.
And if I want to add to what Shawn said, he, as you see, he's the administrator. He counts the beans and the dollars. For the physician, I think Shawn's point to me was, either you see no patient, 0 shillings, or at least see a number of patients at 500 shillings. Something is better than nothing. If we begin like that, then the comfort level comes in to say, you can talk to your patients, and over time, the payer may see the benefit of both physical connection to the patient, as well as those who cannot be connected physically can have telehealth. So I think the answer is in the combination, the marriage of these two, so there's synergy. Not everybody can be taken care of through digital technology, but at least we can separate. And ultimately, if done right, the population will be served will be higher than the population served before COVID. Would you agree?
Yes, absolutely.
So clearly, telehealth is improving the accessibility of some of these services that would otherwise, and as Right put it, it's really a hybrid of those who would have otherwise you'd have seen in person, or those that you'd have seen through the telehealth platform. Hello, sorry, I think there's a phone ringing in the background, just went to mute it. Sorry about that. So just as a follow-up to what you're discussing about how telehealth is really bringing closer some of these services to people. I'll quote something from the Aga Khan University website. It says, "We know COVID has disrupted our lives, but don't let it disrupt your care. teleconsultation and triage allows continuity of care and triaging of current and new patients. Already, the vision is there. The idea to reach more patients, whether virtually or in person, is there. Perhaps Dr. Bolouki could give us a bit of a glimpse about the Aga Khan University telehealth strategy. What is the strategy about? What are the opportunities that you see going into this arena?
You know what? If I tell you my strategy, then you know all my secret. But that's okay. I'm teasing you. Listen, after the experience that we had here regarding the, let's talk about what is difference between a teleconsultation, telehealth, and virtual care. They are not interchangeable. Each one has a different meaning. When COVID happened and we started experimenting with our teleconsultation, I really don't call it a telehealth, teleconsultation. We saw during the lockdown, actually the demand was there and a lot of patients were trying to basically connect with the physicians. And then when the government started to easing the lockdown, we have seen a decline of the demand for the teleconsultation and the patients, they like to come to the hospital. But the conclusion was that, you know what, this is something that we need to think about it seriously. Therefore, one of the areas that we will be looking at and hoping developing an actually strategy is Aga Khan University Center of Virtual Care or Telemedicine. And this has basically different component. And this component, it has to be mapped to the 4 segments that I explained, which is prevention, diagnostic, intervention, and continuum of care. For example, on the prevention, we need to look at the channels of care, okay? See what are the channels of care. And then when we look at, for example, diagnostic and intervention, we have a lot of different areas. And Professor Saleh talked about some of them. We can talk about telepsychology, telemedicine, telenutrition, telestroke. And then at the top of the pyramid, which is actually an intervention, we can even talk about telesurgery. But for telesurgery, you do need a robotic, basically, equipment. That robots, the minimum investment is around $3 million. But you need a 5G in order to be able to actually develop. And then on the continuum of care, it is remote monitoring of the patients that you are suffering from the chronic disease. As Professor Saleh says, if you have the wearable, do you know what? I can basically measure your heart rate, blood pressure, your oxygen, and your weight on a daily basis and tell you if you are on the right track or not. But that's something we are thinking about it, and we are trying to develop a comprehensive strategy around the telehealth and virtual care. Professor Saleh?
No, I think I agree. And we should start thinking about it today because COVID is the beginning of a number of pandemics that will come our way. It's just a practice. And I think if we take this seriously, because there will be other COVID coming down our way with the MERS virus, the SARS virus, that did not impact the economy and our infrastructure as bad as COVID-19 has done.
True.
So I think this is a practice run for the real deal. And come vaccine, and we're the first ones in Kenya to be able to offer the vaccine for COVID-19 very soon. But even at the vaccine, if only half the patients develop an immune response, we'll still have half the patients at risk. So all these things to me, Shawn, are a preparation for the day when virtual medicine becomes a reality, where we do not give up the connection to the patient, but certainly augment the ability to reach out to him. And I believe we should talk about it, but there are risks to that. My privacy is all of a sudden in the cloud somewhere. Somebody can intervene.
Yeah.
Recently, we had a shutdown of the EMR. All of a sudden, there's no connection between me and my patients. So all these opportunities come at a certain cost. We better be able to think those through now to make it a reality for the future.
You're absolutely right. One of the biggest concern is going to be a cybersecurity. And recently, there was even an article in the Standards, which was a warning from the government of Kenya that they are seeing more cybersecurity and attack, on the different organization. We have seen a lot of it in US. And the cybersecurity, for example, or cyber attacks at the hospital, it is not necessarily trying to steal your medical record. It's trying to steal your identity, and then the identity can be basically traded in the black market. And people, they can go and get credit card and loan based on your name. This is one of the, how should I say, downside of the telehealth that needs a huge investment. And as Professor Saleh was saying, there is also a possibility to augment a telehealth with the artificial intelligence and let the patients, actually talk to the computer and get all the information. And then when the artificial intelligence maybe has the preliminary diagnostic, that's the time you bring the physician in basically to look at it and verify it and say, do you know what, I agree with it, or no, do you know what, there is something wrong here. It's a huge opportunity there, and we need to start thinking about it and get prepared.
I think, Shawn, what you bring up is very important. The IBM Watson, developed in New England by Harvard, MIT. You can talk to IBM Watson. It will go back and look at your EMR, come up with issues, diagnostic tests, therapy, remedies. But the IBM Watson has not been modeled for the LMIC, where we don't have all the blood tests. We are far away. We have TB, malaria, HIV, things that we do not see in New England.
India.
So I think we would like to be the model, the place where IBM Watson Kenya is tested, because our patients are different than the ones in North America and Europe.
Absolutely right. Absolutely right. Our challenges are just a little bit different.
Our challenges are a bit different. And actually just want to shift gears a bit. And I like what you talked about, that some of these telehealth and telehealth solutions do not cut across. They'll vary differently. Each location has its different needs, and so they'll tweak it as per their need. I have a question about COVID and the challenge that we're dealing now with the issue of epidemic, that we have technologies is easing all this, that we can easily access healthcare. But then at the same channel is also allowing, or it's also facilitating for sharing of unverified information and verified health information. And of course, knowing that the impact of this is that there's going to be a lot of stigma, there's going to be a lot of wrong information about it, which undermine public health response and such work around COVID response. What is the danger of this, Professor Mansoor? What danger lurks ahead of the pandemic?
Ask me the question more specifically. I wasn't quite sure what you were pointing out to.
Yes, so we're seeing that technology, in as much as it's almost like a double-edged sword. So it gives us an opportunity for us to bring healthcare closer to people. But then at the same time, the same technology and really internet access and communication platforms that would otherwise be used for, say, communication, sharing information on prevention, etc., are also, unfortunately, also being used to pass along fake and confirmed information around, say, COVID protection, prevention, and really the management of COVID. What danger lies ahead, or what danger are we currently facing with the influx of wrong information that undermines public health response and the efforts that are around to keep COVID at bay?
Okay.
So I remember a statement from the Chancellor who said, the IT platform has connected us, but it has not increased information content and value, because everything that goes through these wires is not really validated, accurate. We came up to hydroxychloroquine, the very famous pill promoted by a very famous person. We know today it does not really help. Yet it depends upon who's preaching to the crowd and who's the crowd. And then all of a sudden, the loudest crow controls the music in the air. And that is the problem we have when we have the platforms of communication become unvalidated. So any unauthorized naysayer or yesier can become the pundit. So I think that has become very important. So the source of your information becomes very, very important. Go ahead, Shawn.
I think the best analogy that I can give you is like consuming food. There is a junk food and there is a healthy food. And both of them are available. I think as a consumer, you have a responsibility and see what is it that you want to consume. You want to consume the junk food that is not good for your health? Or are you cautious the way that you look at your diet and you consume the healthy food? Unfortunately, the telemedicine, or how should I say, development of the communication means it created this dilemma. You have a junk information and you have a right information. Then as a consumer, you need to decide which one is the reliable information. And the beauty of Google, internet is that you are not basically restricted to one source of information. If I look at something, I can go and Google it, and there are so many different, source of information that is available. Then it is my responsibility to read it and sort it, and then draw my own conclusion in an independent manner. Therefore, as Professor Saleh says, is a double-edged sword. Okay, is a convenience of access to information, but how do you sort between the reality, fictions, and conspiracy? That's not an easy answer. There is no recipe for it. It's individual dependent.
That's where an institution like AKU, Nairobi, that is accredited by validated and authorized entities, get a stamp of approval to say what you share is important, true, valid, and proven. So we have to really keep up with that standard to really continually be able to match the needs of our patient, ensure that we also are up to par with our knowledge so that our patients really are also informed and can be taken away from misguided information. That's a responsibility for the CEO and for the physicians are really keeping up with technology and knowledge at every instance. And therein comes the issue of trust. Do they trust the stamp of approval of AKU Nairobi? Or would they trust somebody else on the side would say clearly the opposite thing? That's where the responsibility of the institution as well as the clinician comes into play. The platforms are available. Who will be heard? We have voting going on, still not quite declared who's going to be the winner. But you can see the world can be divided by information. We need to be sure that we are providing the right information to the right people in a very credible manner.
I like that it's all about the source, it's all about the information, it's who is telling us this, who is sharing this. I want you also to just talk about the role of civil society and other partners, tying it back to the public-private partnership. How do you see Khan University working with different partners to push and really to advance the how technology can come in to avail access to healthcare to all East Africans?
You know what? I look at it. Yeah, I give you my opinion, and I'm sure Professor Saleh can basically add to it. I look at the partnership. Listen, marriage is a partnership. Am I right? Therefore, in order for a marriage to be successful, there has to be the same vision, mission, and core values. Okay? If people that they want to get into a partnership, they have a divergent values, and they don't believe in a same mission, therefore, that partnership is not going to be successful. Some of the prerequisites basically for a strong partnership is transparency, accountability, and then dialogue. Because if you engage in a dialogue, the result is innovation. The result is out-of-the-box thinking. And the beneficiary of this partnership then is basically the community. But I believe the foundation for a strong partnership is compatibility of the values, vision, and mission. Saleh?
I think I agree. If I look at it, the public sector has to provide the infrastructure, the regulatory environment to allow innovation and not to stifle it, and most importantly, provide transparency so that everybody has a say and the one who has the best idea is allowed to move forward. That's what the public sector should do. The private sector, the civil society, should say, given the regulatory environment that allows innovation, can we be at the top of our game? So there is the institution, AKU Nairobi, AKU as a whole. There is also the individual who say, I would like to contribute to this particular institution because I would like it to grow, because it helped me, it'll help others. And what I would like to see in Kenya, that our population comes up and supports institutions like ours, because they are the beneficiaries of the work we do, and they need to participate in it. So when I talk about public-private partnership, the public clearly is the federal government, institutional authorities. The private sector is us, NGOs, but also the individual. Be it you give time, you give knowledge, or you give resources. All those three are important for this PP, public-private partnership, to be functional and really responsive to the needs of the people.
Thank you so much for the insights and really just unpacking what telehealth looks like, who are the key players, how each party comes in, and how we can, I mean, ultimately it's about the community. How are we serving the communities in a different aspects? And so I'll shift us now to the Q&A. And there's a question here. Thank you, Fatima, for sharing this. The first question is, does telehealth, and so this question could be answered by either, does telehealth bring down the cost of accessing healthcare to low-income patients? If not, does it cost more? In which case, is it worthwhile for vulnerable and hard-to-reach patients who are from low-income backgrounds?
The possibility of bringing the cost of the care down is there. But let's talk about it. I will give you two specific examples. Let's say you do have a patient that lives in Garissa. Am I right? And I have an absolutely fantastic infrastructure for telehealth. Can you guarantee me that person has a computer at home or a smartphone and knows even how to basically download this application? Or the infrastructure is there that they can access it? Now, if the answer is yes, then that person does not have to travel 200 kilometers or 300 kilometers to come to Aga Khan. Am I right? Now, let's take it one notch higher. Let's assume I have a patient that is suffering from diabetes and comes from one of the surrounding countries. Am I right? Comes here and sees an endocrinologist. And after that, she needs to be monitored. And normally what it is, you look at the blood work and some other things. Am I right? Why do you have to do it face-to-face? You can do it through telehealth. You don't have to travel. You don't have to get in the airplane. That possibility exists. But the prerequisite is exactly what Professor Saleh says. The role of government is to basically lay the foundation. Then the role of the private institution is to build upon it. Professor Saleh?
No, I think agree. It requires an initial investment, and that has to come from the public sector. Shawn is the proponent of the upcoming Children's Hospital here at AKU. Regulatory environment has to be permissive. Such hospital has to be provided the resources on the regulatory side to enable it to be existing. We, the institution, AKU, will provide the investment for the building, the technology, and the human resources. It will serve everybody else. But I believe the private sector has to allow that kind of institutional framework to really grow in this system. So I think public sector should provide the infrastructure, ability, regulatory environment. We then have the responsibility to use that in the best manner because we know the needs of the patient.
Okay, thank you for that. Question 2, the question is, what are some of the ethical considerations we need to consider when thinking about telehealth? Dr. Bolouki, could take it up and then. Prof, and then.
I refer to Professor Saleh because from the physician point of view, and then I will hopefully can add to it.
So let me look at it from the oncologist viewpoint, where I see cancer patients. Ethically speaking, the patient wants to be assured that through any of this communication, that their privacy is really intact, that I maintain their privacy, that I usually do not divulge things that they would not want to divulge, because after all, telecommunication could be wide open. We know very many instances where the microphone was on, things were said you did not want to say. The video was on where you did not want people other to see where you were going. So privacy is very important. Confidentiality, very important. In terms of telemedicine, telepathology, the ethical dilemma would be later to say, how is this information divulged, used? For example, you come to me, a young woman with triple negative breast cancer, and you are positive for BRCA, the Angelina Jolie gene, we call it. It's a gene that Angelina Jolie's parents had, and she had bilateral mastectomies because she inherited the same gene. That information now you have is now telling me you are at risk for breast cancer, which you were diagnosed with. You may be at risk of ovarian cancer and maybe even colon cancer. That information now is also relevant to your children, but also to your siblings. Can that leak out? Maybe your siblings do not want to know that they are at risk. When should you tell your children? When they're 6 or when they're 26? Those are the ethical dilemmas. All of a sudden, the bandwidth of telecommunications allows you to disseminate information so quickly, a push of an email button, send. How often have you made the mistake of sending something you wish you had not? The same thing could happen with medical information and medical knowledge.
Thank you, Professor Saleh. Basically, if I may summarize, the ethical principle hasn't changed. You know what? The ethical principle in medicine is not situational. That you say, if somebody comes and sees me, this is the ethical principle, but if I am on the phone, it changes, or if it's telemedicine, it changes. The mode of transmitting the information and the sharing the information has changed. Now, I can give you a specific example. If I am having a discussion with you in my office, it's you and I. But if I have this discussion with you through telehealth, I don't know who else is around you. Have you created that privacy yourself? Now, is it my responsibility or is it your responsibility to create that privacy? That if I share something with you, that to what some degree you want it to stay confidential, it stays confidential. Now, as we evolve this technology, I'm sure we will learn. We will learn what are the challenges and some of those issues that you brought up. Once we have a practical experience, then I'm sure we can come up with the practical solution.
And just to give an example, I think I see patients. I've got the iPhone. The other day I saw a patient and the lesion was growing bigger. I said, okay, let me take a picture. So it's here on my personal iPhone. It's gone to my own cloud. It's a patient's property. Theoretically, I should tell Shawn to give us a dedicated IT-enabled VPN password-protected camera so that the picture goes directly to the EMR. We have not done that. So I think all those little mistakes that we take for granted are going to come to bear. The philosophy of ethical principle has not changed, but the ability to leak information just because of not being very conscious has grown significantly.
Okay, thank you. Question 3. Do you think governments in East Africa will need to start changing the regulatory environment to accommodate telehealth instead of physical visits in a way that is beneficial to the patients?
I think,
Prof, you
do you know what?
then, or doctor? Yeah, sorry.
Listen, in order, one of the experience even in developing world is that the technology is evolving much faster than the regulatory environment. Okay, and there is always a catch-up by the regulator. Should it be? Absolutely. Should it be basically an uniform policy when we look at the telehealth and also IT for the East Africa, that should be developed collaboratively by basically East African countries, yes. Should this system to be compatible, that if you want to use basically telemedicine in Kenya versus Tanzania, Uganda, or Rwanda, that you don't have to go and reinvent the wheel? Yes. Is it easy to do? No. Then basically sometimes I say it is above my pay grade, but I agree that it should be.
I agree. And I think we can learn from the developed world because they face the same issue. They may be ahead of time. However, the environment and society in the LMIC, in the low middle income countries, is very different. So I think we should be careful to realize that there are very many obstacles that others have faced, but their solutions may not be the right for us.
So we have to localize our solutions. We can't, it's not a blanket fit all kind of situation. Okay, question 4. Will telehealth and other forms of artificial intelligence be put in place at the new hospital in Kampala? How will AKU or how will Aga Khan University learn from models in place from the Aga Khan University Hospital in Nairobi?
When you look at basically AKU, right now we are in a process of putting all our institution on a common platform for electronic medical record. Basically, regardless of your point of entry, the medical record is going to be available to the physicians, and it makes it very easy, for example, to obtain the second opinion. The second strategy is we are putting all our imaging departments on a single platform. Now, once we develop our telehealth strategy, it's going to be also a uniform telehealth strategy. Artificial intelligence, it is just a little bit more difficult. There are a lot of debates going on in the US. For example, if I buy a piece of equipment that comes with the artificial intelligence, the whole system should be FDA approved, or each one can be separately FDA approved. We need to learn also artificial intelligence has also advantages and disadvantages. And the best example that I can give you is a MAX 3373. Am I right? The 2 crashes that happened, it wasn't human error. It was because of the artificial intelligence that was not basically integrated properly in the whole operating system of the airplane, and the people that they were supposed to use it, they did not have a proper training, okay? That is just a little bit more complex answer and the complex situation. But as we learn, hopefully, you know what, we can come up with a proper solution. And Professor Saleh might have a different opinion.
No, I agree. And to continue with the analogy of the 737, the company, we will not name it, was cutting costs. So we need to be sure that the cheapest EMR may not be the best, nor may the most expensive one, but we have to really, we are lucky that AKU has a platform in 6 countries. So when we choose an EMR, we choose artificial intelligence, we choose a platform from IT and electronic medical records, it has to abide by the rules and regulations of 6 different countries. Much more difficult because countries don't speak the same language, but if we achieve it, there is no other entity can beat us in terms of the data we can gather, the use of this information for the benefit of our patients. Wouldn't you agree? I mean, Shawn,
Yes.
we are across the borders.
I think one of the interesting things might be, I share some statistics with you. As AKDN health system, we see 8 million patients per year in our health system. We do 64,000 surgeries. We deliver 39,000 babies. We do 28 million laboratory tests, and we dispense almost 10 million prescriptions. Now, just imagine if all this information is in a central location, that becomes basically a hub for a very powerful research, innovation, and comparative analysis, because we operate in different countries. And that is basically what Professor Saleh is referring to, it is challenging because of the different regulatory environment, but it is not an impossible task.
And I think I want to add this whole notion of data science, where you have incredible amounts of data collected over a longitudinal time frame that you can mine it to say, what is the outcome? So for example, through this data that we have in all these countries, if we gave the same drug, aspirin, in Tajikistan, Afghanistan, Kenya, etc., for somebody who was having toothache, what was the outcome? Was the outcome the same? Did that aspirin cause bleeding, peptic ulcer disease, or did it alleviate the pain, or did it cause all of the above? It's quite possible that in a different setting, patients may respond differently. And we keep on talking about the pharmacogenomics of the population. Our population in Africa has a different genome in many ways than the population in South Asia, in Europe, the Middle East. The drugs that work there or the drugs that work in North America that we import all the time to give to our patients may not work as well. But nobody has tried that out. So part of the process we have, Shawn recently expended quite a bit of money from the hospital to establish a clinical research unit, specifically for us to do therapeutic trials here at AKU so that we can see the impact of the genomics of our population on the outcome of drugs. Because whatever you get from the West may be good, but the application to us may be very different.
But that's the time that, as you mentioned. Now imagine in 5 years, we have seen 40 million patients. If you want to do data mining, this will be an extremely cumbersome process. This is the time you might take advantage of the artificial intelligence. By feeding this information to machine and you start doing machine learning, and that's the time it might give you a very, very substantial information that if you have to do it yourself, it's going to take you years, okay? These are the potentials that we are looking at it, and how then you design it and how you tie all these things together, that's a completely different, discussion.
And Shawn, you talk about that. We are going to, here at AKU in Nairobi, AKU East Africa, have the Mind and Brain Institute. Dr. Zulmirali coming down to establish the Mind and Brain Institute. We were having a discussion the other day about data science, how to collect data, analyze, output, artificial intelligence. He was talking about if you talk into a specific machine, just the way you talk can be diagnostic, whether you're depressed, schizophrenic, or in a good mood, or et cetera, et cetera. Well, it'd be very dangerous to even talk to a machine. So I think, but those are all opportunities. We just have to find the right application for each opportunity. And being on a platform across nations allows us the capability that really very few other institutions have.
Just to add to that, recently I was reading an article that MIT has developed an artificial intelligence that by coughing, when you cough, it can tell you if you are COVID positive or you are not COVID positive, okay? That is fundamental in expediting, for example, diagnosis of COVID.
Shawn, that sounds like the dog who can sniff cancer. We gotta figure it out.
Okay. Clearly, the importance of technology in healthcare cannot be emphasized enough. From diagnosis to prevention to monitoring to the continuum of care, really, technology is critical to availing, the accessibility of healthcare to especially far to reach communities, and also really bringing everyone inclusivity into accessing some of these services. And if anything, COVID has really taught us, and Prof had alluded to this, that this is our dry run. This is now, it prepares us that we need to think of what does this mean, because pandemics are not stopping, they will come. So this is the perfect time for us to think about telehealth and the opportunities that exist. Of course, being very aware of the challenges that come with it in terms of the privacy issues or the ethics and the myriad of concerns that we've discussed in this webinar today. I thank you both for your time, for the discussion, and for the insights, and also the questions that were shared as well by our audience. Just before we close this, I know Professor Saleh, there's a webinar that you're planning in the next 2 weeks. Perhaps you could talk about that as we wrap up.
So we'll be talking about cancer because I'm an oncologist, and because in 2011, the chancellor, when he opened up the Heart and Cancer building, Heart and Cancer Center building, he was very keen on the fact that we have to focus on education and research. And part of my recruitment is to do the same for cancer. And before I end, and I'd also like Shawn to maybe make a point about that, we depend very much on the institutional infrastructure of the public sector, but also the goodwill of grateful donors, individuals who've benefited by the care we've provided because they've seen good in what we've done for them. And in turn, they feel an alliance, an allegiance with us to say, you've done good to me, I'd like to do the same good to others. Here is my contribution. It could be in terms of time, voluntarily, in terms of knowledge, or human resources, or financial resources. Many of the buildings you see here are the output of grateful donors who've helped us become who we are by contributing to our cause. I think that is also very important. And my discussion next week or the week after will be about cancer. Shawn, what about contributions that our grateful donors have done to us?
Yes, I have to really thank basically all the generous donors here. And one specific example that I can basically give, which absolutely transformed the delivery of the cancer care in this part of the world. When I came here as a CEO, I saw we have the infrastructures for delivering a high quality, basically cancer care, but we didn't know how effective it is. And we didn't know, what would be the right course of the treatment? If somebody has full metastasis in their body, why do you want to make their life difficult? One of the shortfall was we did not have a PET CT and cyclotron here. And in a conversation that I had with the president, I said, in order for us to really provide a comprehensive care, this is one of the areas that we need to focus on. We had a very generous donor that they do not want to be named, provided around 30%, 40% of the cost of this equipment. And because of that, we were able to invest 600 million shillings to bring the cyclotron and PET CT here. And the cyclotron that we have at Aga Khan University Hospital, you can basically independently verify that one with GE. We are the first hospital in the world that has this cyclotron. Now, the byproduct of that is nobody has to go out of the country. And we are getting patients from the surrounding country that they are coming to Kenya, and they are not going to Europe or they are not going to US. Then in order to build upon it, we decided to also design Aga Khan University Children's Specialty Hospital. And two areas that we would like to focus by building this hospital is also pediatric oncology and bone marrow transplant. And we believe that by building this hospital, we can basically transform the delivery of the pediatric care in this part of the world. And my philosophy is the children are the future of each country. Take care of them today, you will have a brighter future. And those are the other things that we are working on it to basically to make sure, not we are addressing telehealth, that we will look at the needs of the basically healthcare needs of the East Africa in a very comprehensive and wholesome manner. And without the generosity of our donors, some of our accomplishment would not have been possible. And we are very thankful to them.
So I'll take the last word from Shawn, although usually he has the last word. While the children are the seeds of the future, it is the mother who is really the central figure in any family. So beside the Children's Hospital, we are dedicating ourselves to a women's cancer center, specifically dedicated to the aids of a woman, because at least in Kenya, East Africa, cancer is one of the biggest causes of mortality for our mothers. So between him and me, I think we will take care of the whole family. The fathers, they can donate, the mothers will benefit, and the children of the world will have the product of that.
Okay. Okay, thank you so much for that. The audience, you have something to look forward to, both as the upcoming webinar and also what the Aga Khan University has planned out and really rolling out in the coming months, in the coming years. I thank you again for taking time, for the insights, for the discussions. We don't take it for granted that we have a platform using technology right now for us to interact and to share and to engage. Until next time, I was your host, Eunice Kilonzo. Thank you very much. Bye. Thank you.
Thank you. Bye. Appreciate it.
Bye.